We were going to have a Q&A, but as we all can see, we're kind of running a little behind time. And I want to make sure that all speakers get an opportunity to speak, as well as we get to kind of the work of today as well. And so next, I want to first thank Dr. Neil Calman for providing an awesome switch and a quick and last-minute switch for us. But many of us know Dr. Neil Calman. I heard his name, read his name years before I even met who he is or who he was. So it's really exciting at this point in my career to actually be working with him as well as his team at the Institute of Family Health. He is also the chair of Mount Sinai's Department of Family Medicine and Community Health, which was launched in 2012, so not too long ago, in collaboration with the Institute for Family Health. And he is the President, Chief Executive Officer of the Institute of Family Health, which is one of the largest networks of community health centers in New York State. So without further ado, Dr. Neil Calman.
So this is actually an amazing time. I was watching television last night. I thought, wow, to talk about racism at this moment in time, when the leading Republican candidate is the most vocal racist that we've seen in a really, really long time, is amazing, absolutely amazing. And what it says about so much of America and how far we have to go, I think is really terrifying. I'm sorry, but to me, listening to him is just absolutely terrifying. So they gave me 15 minutes to talk about work that I've been doing my whole life. Not an easy task, but I'm going to try. So what I really want to talk about are the structural parts of our healthcare system, the things that we actually can do something about really, really easily, I would say, and to show you a little bit about the work we've been doing. So we no longer have those signs that say coloreds in one direction and whites in the other, because we've developed much more subtle ways of creating a racist healthcare system. What we really do now is, first, we maldistribute insurance by race. You see what we do around people's neighborhoods, and you saw what that was like. And then we have a healthcare system that separates people based upon the type of insurance they have. And guess what? We have de facto segregation by race. And it's subtle, much more subtle than the signs, but I think even more devastating, because the people who are in different parts of the system don't even know often that they're being discriminated against and that they're getting inferior care. So I had only one slide to summarize what I spend an hour talking to medical students about. This is my favorite slide. And basically what I did was I plotted the racial distribution of the population of the United States by age. And what you really see is the devastating effects of racism in our society and on people's life expectancy. So this is the whitening of the American population with age due to the premature death and disability of people of color. I don't think there's any single slide that can summarize all of the diseases and all of the things that you saw Dr. Bassett talk about. And then on an international front, our healthcare system is embarrassingly poor. We have the poorest quality, the worst efficiency, the poorest patient safety, the poorest longevity, the highest costs, and the worst equity of any of these developed nations. This is from a Commonwealth Fund report. So how does it start? What happens in New York City, and all of what I'm going to talk about is about New York City. What happens in New York City is, first, we distribute health insurance inequitably. So 31% of Latinos are uninsured, 12% of whites, 19% of blacks. And you'll see why this is important next. We also distribute Medicaid according to race. And so Medicaid, which is intimately tied to poverty rate, so 58% of Latinos are on Medicaid in New York City, 43% of blacks, 19% of whites. So wow, if we wanted to create a discriminatory healthcare system, all we need to do is to develop a system where people on Medicaid and the uninsured go to one place and private patients go to the other place. And that's what we have done in New York. And that's how we systematically exclude people. And you will see what I mean in a minute. This is another slide that we developed. So every one of these bars on this chart is a hospital in New York City. There's 60 nonprofit hospitals in New York City. The little blue arrows on the left, on the upper left, represent the public hospitals. The yellow bars are the percentage of people, of discharges from each of these hospitals, of folks who are on Medicaid. And the little colored bars at the bottom are the percentage of people, of discharges in each of these hospitals who are uninsured. So there's two horizontal lines that you see. Let me see if I have a pointer. Oh, yeah. No, I don't. Oh, the red dot. There we go. So there's two, thank you. There's two horizontal lines. So this represents the percentage of New Yorkers who are uninsured, around 20%. And when you add to that the percentage who are on Medicaid, around almost 19%. So about almost 39% of people who are uninsured are on Medicaid. So I think the astounding thing about this is, first of all, look at the distribution of hospitals that we have and how we've managed to sort of separate people into these institutions that largely take care of people who are uninsured and who are on Medicaid. And guess who those are? I just showed you. And then this whole other part of our healthcare system, nonprofit, tax-exempt hospitals that aren't even taking care of their proportionate share of people who are poor, right? Underrepresented in those hospitals, and still tax-exempt charitable institutions. And so one would think, well, who are these people down here? Well, let me show you. So the people at the very bottom of the list happen to be, So the people at the very bottom of the list happen to include the specialty hospitals, right? Rusk, Rehab, Hospital for Special Surgery, less than 3% total population, okay? Memorial Sloan Kettering, Joint Disease, and Calvary, the only sort of full hospice that we have in New York City. And those are the folks sort of at the bottom of the list. Okay, so what does this really mean? Well, only 16 of the 50 private hospitals take care of their proportionate share of people on Medicaid and the uninsured. And this is all sort of on the inpatient side. And these institutions are still considered tax exempt. But there's also huge issues related to their economics, which I'll tell you. So one of the things we hear whenever we show this is, well, let's look at the neighborhoods. And I was so glad that Dr. Bassett talked a little bit about history. So look at the history about where and how we distribute this. This has nothing to do with neighborhoods. This is those same charts, but for hospitals that are literally on the same block or side by side. And my history has a lot to do with this dyad right here, because I started my residency at Montefiore, and who said yay? You're not going to say yay for long. Part of that was Morrisania City Hospital, and in 1976, I sat in Morrisania City Hospital as they were closing it and moving all of the patients up to North Central Bronx. Don't clap for that either, because North Central Bronx and Montefiore were connected by hallways so that when patients got admitted through one or the other, we could separate the people and wheel the patients without even taking them outside, wheel them into the other hospital where they, quote, belonged. But look, Jacoby and Montefiore-Weiler, look at the differences in the uninsured and the folks on Medicaid in these institutions that are literally, on the same block, or a block away from each other, or in the same neighborhood. How do we manage to segregate the population of patients that are cared for in New York like this? I mean, it's really quite astounding when you think about how well we do at this. And another part of the inequity in the system goes around financing. So I want to point this out. This chart, the little blue dots here, and I hope you can all see those, are the public hospitals, and what we plotted here were the number of self-paid discharges, the number of uninsured patients that are discharged from these hospitals against the amount of funding they got from the distressed hospital pools to sort of support this. But look at this, a public hospital with 1,200 uninsured discharges that got $15 million, while a private hospital got $28 million from the same fund. And you can look across the same way. Here's two hospitals that got $13 million. A public hospital that had to do 1,500 uninsured discharges to earn that, and another one that had just 300 or 400 uninsured discharges that got the same amount of reimbursement for taking care of people who are uninsured. And if you think about what you've been reading in the papers right now, NYU just reported their net profits for 2015 of $228.9 million. Net profit, okay? At the same week, in the same newspaper, the Health and Hospitals Corporation, our public hospital system that takes care of the other folks, reported a net loss of $264 million in the first quarter. One was the whole year, in the first quarter. Projected of almost $1 billion in losses in one year. So we separate people into different systems, and then worse, we underfund one of those systems, and the system that takes care of the poorest, neediest, and sickest population. That's what New York City hospitals look like. Well, if you're lucky enough to get into one of the private hospitals, it's not all good news from there either. The next thing we studied was what happens to people in those institutions, especially in relationship to outpatient care. So we run a system that does close to 550,000 outpatient visits, and all of those are primary care. And so everything that we do at the Institute depends upon the network of academic medical centers who we refer to in the neighborhoods that go all the way from Kingston, New York, down to Lower Manhattan. We are dependent upon those places to deliver specialty services. And what we all know is that every one of these academic institutions completely separates people based on their insurance, which, guess what? De facto segregation by race. And how do they do that? They establish these things called faculty practices. And faculty practices escape what Dr. Barrett explained was the Medicare sort of rule that you can't discriminate, and they escape it by claiming that they are truly private practices that exist within the walls of the institution. So when you start to bring complaints and charges against these institutions for discrimination, what you find out is that they are protected by the fact that these faculty practices are sort of established with the hospital's logo, with the hospital's business cards, with everything else, but established organizationally and structurally as private practices. So they're exempt. They can discriminate. And so what you do is you don't credential those doctors in the faculty practices to the Medicaid managed care plans, and you don't credential them to Medicaid. And then when patients call the institution, you say, if you have Medicaid, you go to the clinics because our other doctors aren't able to care for people on Medicaid. And what do you do in the clinic system? You don't credential those doctors to private insurance companies. So what you're really doing is not discriminating, mind you, so don't anybody get the wrong idea. You're just sending people to where their doctors can accept their insurance. And that is a subtle but very, very effective way of caring for people in separate systems. And I've outlined here the different ways in which this works. So we know that the providers and the faculty practices, in some institutions, residents and fellows are not allowed in the faculty practices. There's continuity, people have private doctors, there's good coordination of care, there's night coverage. When you call the faculty practice, you get an answering service that connects you with somebody in that practice as opposed to having a message machine that tells you to go to the emergency room. and doctors actually care for their own patients in the hospital. So we have two completely separate systems of care. And I'll give you one example of what happens when you separate people like that. And you have people who are vocal and they pay their bills and they're vocal, the consumers, and people who feel like there's sometimes that they're lucky to get whatever the hospital is willing to give them. And so this is what we studied was next was what happens to our patients when we send them in. Now, the blue lines here are the people who keep their appointments. And lo and behold, if we get an appointment with one of these specialty clinics within 2 days, over 80% of their people keep their appointments. But if you have to wait 2 weeks, that drops to 25%. And if you wait 30 days or more, it's down to about 12%. Why? Because if you tell somebody they need to go see a cardiologist, they think, hey, there must be something with my heart. I better go see a cardiologist. People aren't waiting 30 days to go do that. They'll go somewhere else. They'll go to one of the public hospitals where they can actually get access if they need it. So what happens? I keep hitting the wrong buttons here. So this was one of the hospitals that we studied, one of our referral hospitals, and you can see that the waits here in all of these cases were more than 20 days on average, and in some cases were 100 or 120 days. And a group of students that we sent out studied one of the institutions, and here's what they found out. They found out, and this was the same institution, and they did this with secret chopper calls, that if you wanted a primary care appointment, you could get one in 3 days in the faculty practice and 20 days in the clinic. For dermatology, it was 2 days in the faculty practice and 50 days in the clinic. For endocrinology, it was 29 days in the faculty practice and 54 days in the clinic. And for GI, it was 24 days in the faculty practice and 69 days in the clinic. Orthopedics, okay? 7 days in the faculty practice and 77 days to get an appointment in the clinic. And we've been tracking this over time, and it hasn't changed. And it's not that people don't know about this, but where do you put the resources? Where you have private patients who are paying with private insurance, or if you really want to keep that kind of separation that you saw in the hospitals and you want to make sure that the people who are admitted to your hospital are mostly people with private insurance, you do this, which basically scares people away, shows them that you're not really interested in taking care of them the same way, and they go someplace else. So we have lots of ways of sort of making this work. So I'll just tell you a little bit about our coalition called Bronx Health Reach, which started in the late 1990s. And basically, because you're talking about coalition building today, and I want to share with you just a couple of things that we learned. So more than a decade ago, we got together to try to address the issue of racial discrimination in the healthcare system and bad health outcomes in the Bronx. And that last meeting, I'm told, which I wasn't at, had over 90 different organizations, including the health department, present at every one of our meetings. And those meetings talk about everything from how we're going to change food. We talk about things related to the kind of exercise programs that exist in our school systems, and we also talk about racial discrimination in the healthcare system. Why? Because people have to know that they're not getting the best care that's available. People have to know that they don't have to wait 77 days for appointments, but there are other places where they can go, where they can get care more timely and in a better way. And so I'm hoping that we're going to be able to get headlines like this for the coalition to end racism, that we're going to be able to continue to show the public that, that these are important issues that have to be dealt with. And one of the things we learned through this is that articles that you can get in the paper and the press are very important, but so is having a voice. And so we bussed 550 people up to Albany. This is a very interesting piece. This happened right after we brought together healthcare civil rights leaders from all over the country to talk about how we could address this issue of institutional racism in the hospitals in New York. And their advice was something I'll never forget. at the end of a full day meeting like this, with all of these very, very prominent people in a room, one of them said, and then was applauded by all the others, that you shouldn't sue the hospitals, you shouldn't even bother to file a legal complaint, that those things would just tie our hands up for decades. And they cited a bunch of things that have been in the works and have been sort of working their way through the legal system. They said coalitions are the way to make change, that getting people's voices raised, that making a coalitions of people from many walks of life, making sure that people understand the way the system works and helping people to make those changes, bringing them together, did this. So we went to Albany on a great freezing cold day to demand this, that we expected to end discrimination in healthcare. And I have two proposals to do that are really, really easy. One is to just demand that the institutions that we work within end any and all practices that separate people based on the type of insurance they have. Because as long as we maintain that differentiation, we will not end the racial discrimination. And second, and I came up with this idea on the train coming in this morning, we should tax the profits of all of the private hospitals in New York and pool all of their money and give it to the public hospital system. Because the public hospital system is taking care of the people that they turn away. So let's just take 50% of their profits, which I calculated by looking on my cell phone, and give it to the public hospital system, and we will solve the discrimination in funding that will enable us at least to have a safety net that's well funded and able to do what it needs to do. So, like these wonderful ladies said when we took them to Albany, we need to end the discrimination that still exists in healthcare. And I want to end with a quote that's especially meaningful to me, because I am here because of the end of another type of racism that existed when my mother, who was born in Germany, lost most of her family in the Holocaust. And Elie Wiesel, who is a Nobel Peace Prize winner, in his acceptance speech, said something that I think is incredibly meaningful in all of the work that we do. He said, "And that is why I swore never to be silent whenever and wherever human beings endure suffering and humiliation. We have to take sides. Neutrality helps the oppressor, never the victim. Silence encourages the tormentor, never the tormented. Sometimes we have to interfere. When human lives are endangered, when human dignity is in jeopardy, national borders and sensitivities become irrelevant. Whenever men and women are persecuted because of their race, their religion, or political views, that place must, at that moment, become the center of the universe. I think we're at the center of the universe now and have a great opportunity to change. So let's make health equality a reality."
Hello.